At the outset, I want to thank Dr. Aditi and Dr. Viraj for inviting me here, and as well as the Shelby organization. And before I start the presentation, I want to thank Dr. Aditi again and Dr. Sanket Mehta for giving most of these videos. So, total parietal peritonectomy for ovarian cancer. So, as far as peritonectomies are concerned in cytoreductive surgery, there are visceral parts and there are parietal parts. So, I'll be presenting about the parietal part today. So, there is a debate. So, I'm not going to go into the details of selective versus total parietal peritonectomy. Of course, patient selection, optimization, and teamwork is important. So this is the usual setup in which we operate. It's a French position where you can afford to have two first assistants. It makes the surgery easy and a little bit quicker. Of course, you need good quality surgical tables with leg splits. Some prefer to use ball tips and some prefer to use the routine spatulated cauteries. I operate at these settings, pure cut at 150 and cautery at 80. So we also need a good set of retractors so that we get adequate exposure in all the areas. And we start in the midline and we go towards the peripheries. Unlike other surgeries where we are going from region to region, we approach all the regions simultaneously so that we are not getting into a hole. So I put a shape of the human cell out to just to orient you guys to the which part is the head end. So we start with a large midline incision. Here the rectus sheath is elevated and preperitoneal plane is getting created in the anterolateral areas. So we can do this either by blunt dissection or sharp dissection. Blunt dissection causes a little bit more blood loss. It's better to achieve hemostasis then and there so that this minor ooze is controlled. So once that part is done, will be good to apply retractors, and this is the peritoneal cocoon, how it looks if it is done neatly. So let us see the left iliac fossa part of the pelvic peritonectomy first. So we identify the gonadal vein and we identify the ureter. Ureter goes down and the gonadal vein comes up in the specimen. Once we lateralize the ureter, we enter the TME plane, something similar to the rectal cancer resections, and from there we go deep into this TME plane. This is essential to pull out the pouch of Douglas peritoneum and the rectum up out of the deep pelvis. Similar steps on the right side as well. You see how the assistant is retracting the ureter, and so this action has to be reversed, and sometimes the ureter may be stuck to a large ovarian mass near its closer to the bladder, where you need a combination of blunt and sharp dissection as shown here. So I usually stop this lateral dissections around the obliterated umbilical artery. That gives us a good landmark. So coming to the bladder peritonectomy, you can either approach it from midline or you can approach it from lateral based on your preference. I usually approach it from the lateral side. I find it very easy. You can also palpate the Foley's bulb, which will give a guidance as to where the bladder is ending. In thin peritoneums, buttonholing is possible sometimes. After the initial parts, once you enter the cervical part, it is quite easy. So as you can see now, we are joining the lateral and the midline dissections, clipping the obliterated umbilical and slowly approaching the uterine vessels. Here care needs to be taken that you are not breaching the peritoneum. If an excessive dissection may puncture the peritoneum on these sides. can either clip or ligate these uterine vessels. Similar steps on the right side as well. So this is the colpotomy, and we need to be a little careful while dividing the posterior vaginal wall so that we are not puncturing into the pouch of Douglas. It may be at varying depths depending on the patient habitus. So the posterior mobilization helps in lifting this pouch of Douglas easily, and then we also need the lateral mobilization and opening of the non-villous fascia, so which this straightens out the rectum and the pouch of Douglas comes out easily. So as you can see, with little bit of finger dissection also you can lift it up. So ultimately most of these rectal infiltrations are in the upper part of rectum and not in the middle or lower part. So majority of this rectum can be saved. So now we are dividing the mesorectum, and as you can see, it is mostly in the upper rectum, the division is. So this is how the end result of a pelvic peritonectomy looks. So coming to the right diaphragmatic peritonectomy, we need two approaches, one from below and one from above. Some prefer to use coax current. I still prefer to use cutting current, and once we reach the central tendon, there is no peritoneum, you can use a blunt finger dissection. The same way here as well, once you notice the change in the direction of the diaphragmatic fibers, we can connect the inferior dissection to the superior dissection and flip the right lobe of liver completely. Lifting the peritoneum of the anterior gyrotous fascia. This peritoneum gets reflected back close to the bare area of liver. The depth can be variable, it can reach up to the IVC also. So finally we need to dissect this hepatorenal pouch so that the entire right diaphragmatic peritoneum comes out in en bloc. Thin diaphragmatic peritoneums can open up in certain places. Sometimes if there are infiltrative deposits, we also need to take part of the diaphragm onto the specimen, onto the peritoneal specimen. This is the left diaphragmatic peritonectomy. The steps are essentially the same, but here we need to be careful. Once we are crossing the spleen, the fundus of the stomach is quite close to the cautery tip. We have to be a little careful with that. As you can see, the fundus is popping out posterior to the spleen. So once that part is done, we are going to complete the diaphragmatic peritonectomy by releasing it from the attachments to the liver. So coming to the greater omentectomy, we need quite a lot of mobilization, sometimes of the hepatic flexure as well. and definitely of the splenic flexure, so that the omentectomy is complete. On the right side, as we all know, the 4 layers of the omentum are fused, so we need to be a little patient and create the plane just like how we do it in a right hemicolectomy. Come closer to the D1 and D2 part, reflect the entire greater omentum up, and then start reflecting it off the transverse mesocolon. You may find some surprising deposits near the tail of the pancreas and splenic hilum. For an ovarian cancer, we usually preserve the first 5 to 6 centimeters of the right gastroepiploic arcade, and then we divide it, and then we take the entire omentum from the greater curvature of the stomach. Here we had seen that there is already a deposit in the splenic hilum, so it was decided to do a, we had decided to go ahead with the splenectomy along with an omentectomy. So removal of falciform sometimes also requires dividing this hepatic bridge, so that we are not going to miss any peritoneal deposits at the root of the falciform. Even cholecystectomies can be sometimes tricky because of the deposits around the neck or cystic duct. Coming to the lesser sac, we need to reflect the peritoneum of the lesser curvature, then reflect it onto the right crura, and then take it onto the IVC. And this can also be connected to the dissection that has already been done on the right side, and shift the plane of dissection over the IVC from right side to the left side. So we are going quite close to the RNTS ligament and exposing the caudate lobe. Then this dissection gets reflected onto the lesser curvature, then onto the right crura, and then to the IVC. So this is reflecting the peritoneum of the right crura now. We also need to inspect the appendices epiploicae, which may have deposits. Small bowel also needs to be walked through. Sometimes there are deposits near the mesenteric border which are hard to identify, and all those need to be excised as well. Sometimes we'll be able to preserve the rectum, but again it depends from case to case, it may vary. It needs a combination of blunt and sharp dissection. There will be significant amount of ooze from the rectal side in such maneuvers. Thank you very much.